redone more cases because the patient wants to do it lighter because the doctor wanted, like, oh, you don't want BL1, trust me, you want A1. Guess what? 2 weeks later, after you put the veneers in, you're cutting them off because they want to do that.
So let's do this. We'll go live right now, and that'll be like one of the first things we kick off with, like kind of that conversation.
This is going to be great. Thanks again, Brian, for putting all this together, Dr. Harris.
Go.
So we'll go live now, and we'll have a little conversation as people are hopping on.
Okay, sounds good.
All righty, guys. For those that are on early, welcome to tonight's webinar. So we've got a good one tonight. We've got a ton of people logging in right now. So let's give it maybe a minute or two to get everybody logged in, and then we'll do actual introductions. But hey, I don't want to embarrass you guys, but I see like behind you it looks like a show-off wall. Tell me while we're getting people logged in, tell me what that is. I've heard what it is. I've never actually seen it in person, but I hear all the rumors of it. Tell me what it is. It's kind of cool to.
Yeah, you know what? This was back, a few years back when they had Smile Awards at the AECD, and so over the years we had some pretty good years with our Smile Awards, and so just medals on our wall and that we put up, and it's kind of nice to have that kind of a little feather on our cap that was a very, very special thing for us through the AECD and such. So we decided to put them up on the wall amongst us, different smiles and things like that. That's what we do. We're passionate about it, so we like to, celebrate our successes,
Little wall of fame internally.
I love it.
For us.
Yeah, so I've got all my awards on the wall behind me too. I don't know if you guys can see them.
I think they're off to the side.
There's so many, they're so small. It just looks like it blends. No, it's super impressive. And that was, frankly, that was one of the reasons I wanted to do this tonight with you guys. So we're good. I think we're going to start now. I can see a bunch still logging in, but we'll go ahead and get started. For those, as questions come in throughout the webinar, just ask. The whole purpose of these is to be, here to just provide value. And that was the intention for both of us tonight, is come in, provide value, help everybody see that there's possibly a better way to do things in your practice. So we titled this, how to get more predictable results with cosmetic cases and do more of the dentistry that you actually love to do. And I believe both of those things are possible. I think sometimes in dentistry, it's hard to see that. So I'll do a quick intro for those that don't know me. I'm Dr. Brian Harris, practice in Phoenix, Arizona. And, I love designing smiles. I love the cosmetic side of dentistry, but truly what I really love is connecting with people and working with people to help them achieve what it is that they really want. But I've got Frontier Dental here. They really don't need an introduction. Both Brent and Gil are very well known in the cosmetic space. I won't spoil the introductions, but Gil, why don't you go first? Give them an idea of who you are, and then Brent, if you go next, that'd be awesome.
Sounds good. Thank you, Dr. Harris. I'm Gil Villabasir, but forget about the last name. Just call me Gil. And we're here at El Dorado Hills at Frontier Dental Lab, and it's just a little bit outside of Sacramento. And I handle, easiest way to think of it is I handle everything outside of the lab. They don't want me here sitting at a bench. And then my colleague, my business partner, my lab partner, Brent West, handles everything inside the lab. So I'll let Brent introduce what he does in himself.
Yeah, hi guys. My name's Brent West, and with a great team that I have here in El Dorado Hills in Vancouver, British Columbia, our goal and our passion is to create great smiles for our dentists and for their patients. And, our job is to make the patients look good, make the offices look good. And it's something that we do a day in, day out basis. And we've done a lot of cases over the years. And I was fortunate enough in the early days of kind of cutting my teeth, so to speak, is being involved with PAC Live with Dr. David Hornbrook, Dr. Michael Gazarski, and ironically, Dr. Harris's father, Dr. Joe Harris, I know very, very well. And then I got hooked up with Aesthetic Advantage with Dr. Rosenthal. So I happened to be in the right place at the right time as we developed the Frontier Smile, and we do it, day in and day out. And it's our passion, and it's being able to give back to dentistry and be able to change people's lives is something we do every day. And Gil tells the great story through his social media, and it's just pretty excited about what we do with the team that I've got here.
Well, yeah, so two things there that I want to dive into a little bit later that are really cool. One, that you actually have like a process. There's like this process, and there's this methodology that you guys use that really sets you apart from most other labs. But then you also have Gil on the other side of like mastering the game of social media, which, as we know, I mean, that's where business is done nowadays. And so we'll dive into that in a minute. But I'm going to start with kind of a somewhat controversial question. And I want you guys to be like real and honest, because for those that are on here know me, like I have like nothing to hide. I will be as brutally honest as possible, just because I think that's the way that we really learn. So the question of ideal aesthetics. So I was in a lecture this past week with somebody that was speaking, somebody I actually look up to and is just like a phenomenal speaker and like an amazing, amazing artist. And the lecture was on, what truly is ideal aesthetics. And they started putting up some cases and saying, hey, is this ideal aesthetics? Is this ideal aesthetics? And people are like, no. And I was waiting for him to put up one of my cases, because all the cases he's putting up were like bright, bigger, fuller, like white teeth. And I was like, oh shoot, he's going to use me as an example. But I joke about that because those that do follow my work know that, my style of dentistry has changed over the last few years, because I believe ideal aesthetics isn't necessarily like artistically what looks the best, with more triangle shape and translucency and anatomy. And that is amazing aesthetics if that's what the patient wants. But, a lot of the cases that you see on my page are purely patient driven. And so this idea of ideal aesthetics, and I want to talk about this for a minute, because Brent, you said something to me recently in a conversation about having to cut off cases for doctors and how horrible it is when you have to redo cases. And that's happened to me plenty of times. But when we as dentists drive the final aesthetics, and when we make those decisions for patients and don't let them have a voice, that is probably the number one problem that I see, in cosmetic dentistry, in the times where it's been the most stressful for me. So I guess my definition, Brent, and this is more for you as a ceramist, my definition of ideal aesthetics is like sitting down and getting really clear with the patient on what they want. And I have them bring me smiles of other dentists of whatever they want. And then we decide together, like, hey, are you looking at more of this type of smile or this? And then my goal is to give them exactly what they want, instead of being the sole decision maker. How has that impacted your business in the last few years? Because I'm sure you've seen the trends shift and change. Like, what does it mean to you guys?
Well, yeah, I think you're absolutely right. A lot that you said there, but ideally, I always tell people, sometimes we do have actually patients come to the laboratory and we do little consults and stuff like that. And a lot of times they'll say, what do I think? And then sometimes I push it back on, like, hey, I'm not the one wearing it. You're the one that's going to be wearing this here. So I really think that the mistakes happen sometimes when we don't involve the patient in what can be done and what looks good. We have to listen to what they say. That being said, we can help guide them and everything like that. But really, everything is patient is driven ultimately, because they're the ones paying for it. They're the ones who are going to be wearing it. So, it's not unusual that we have a 90-year-old patient that wants long, toilet bowl white teeth. And I tell my clients that don't talk about it. That's because that's what she wants. And of course, there's certain guidelines that we want to make sure that we follow, with the golden proportions and the length-width ratios, and having good something that looks halfway decent. But I think it's a mistake when a patient tries to speak of what they want and they say, no, you don't want that. And let me give you an example of that. I see it a lot as far as shade goes. And I've been fortunate to be chairside a lot of times. And sometimes I've seen, like, you know, a patient, they put the temporaries in, they start going through what the color is going to be. And someone says, the patient says, you know, hey, can we go a little bit lighter? And the doctor says, Mrs. Jones, you know, I think that's going to be plenty light, you know, and I don't think we should go any lighter. I really think we should be like a B1. And they say, well, I really like that BL2. Can't we do that? Mrs. Jones, I think you're not going to be happy with that at all, you know. And then she goes, okay, great. Do the case, everything, and then we put the case, you know, the case is inserted like on a Friday. I guarantee you Sunday night at 9 o'clock, you're either going to get an email from the patient or a phone call from the patient saying, you know, Dr. Harris, I know I said I was happy, but I got to tell you, I'm not happy. So the next week you're cutting them off and everything. And so you have to be able to listen to them. And as I, you know, talk to dentists on how they converse with the patients, usually they listen to the patient, they say, yes, we can do this. No, we can't do that. You know, obviously if the patient says, hey, I want to have 15 millimeter centrals and they're not going to fit function wise, everything like that, you know, Mrs. Jones, we can't do that for you because that'll cause you harm rather than good. But if they want to have, if a female patient, for instance, wants to have what we kind of term as more masculine teeth, and they want to have like that Hollywood look, and they want to go bright whites like that, that's what they want. And I think it would be detrimental to be trying to talk them into something like a 1M1 shade with open embrasures and a nice youthful look. They have it in their mind what they want to drive. I always say they always want to have, if they want the red Corvette, they want the red Corvette. Don't talk them into the blue Corvette, you know?
Well, and I think this is a good conversation, because I think what's happened over the years is, before it was a patient and a dentist having a conversation, and the patient was only influenced by the dentist. And they would get what they got and they wouldn't really know what to compare it to. Social media has changed everything. Because now it's like, well, no, then they can go back and they can search 100 different dentist photos and see before and afters and be like, wait, all these other patients got the color that they wanted. Like, no, I wanted this color. So I think that's one thing that doctors listening, you got to recognize that the world is different in cosmetic dentistry. It's so much more of a patient-driven process, in my opinion, now than it was before. And that doesn't need to be a negative thing. You know, to me, that doesn't mean people are picky. To me, you want people to tell you what they want. It's that much easier to give it to them. You know, if they choose what they want and you give it to them and then they don't like it, no, then it's on them. It's easier to then go back and reshape or do things differently. But I guess that was my big takeaway from that first question was, ideal aesthetics is whatever the patient feels is ideal aesthetics. Don't try to box people in a certain style, or you will cut off 10 Emax veneers or crowns and burn through 50 diamond burrs. I've done it before, more times than I will care to admit on this webinar, but it's happened a lot. So, okay.
Yeah, you know, and here's some of the things that have happened also. Sometimes we'll, you know, even to this day, we'll get a case from a dentist, maybe like a 6 or 8 or 10 unit case, and we won't have really much in the way of direction. No diagnostic wax up, no temporaries. So we'll call the doctor and we'll say, okay, what is it you're looking for? And here's the kiss of death when they say, oh, don't worry, the patient is not that cosmetically driven. Just do a nice smile and everything like that. It's like, okay, we'll do a nice smile. Guess what? All of a sudden, that patient that's not cosmetic driven is now married to you for the next 6 months of redoing case over and over and over again because there was no direction at the very, very beginning. And it's just, any dentists who've done any cosmetic cases have been through that before, I'm sure. You know, oh, Mrs. Jones, she doesn't really care that much about the thing. Just go ahead and make a nice smile. Well, you know, it can bite you. So.
No, it can. So let's, we brought up, I mean, we're talking about color, and we're talking about ideal aesthetics and color. And I think one of the tricky things nowadays is the materials. Everything's shifted, you know, and I've been practicing for about 15 years, and early on, everything was Empress. It was like Empress or you were doing feldspathic. And then Emax came along, and you only used Emax on certain cases because it just didn't look nearly as good. Well, now, I mean, for the last probably 5 years, maybe even longer, 6 years, 100% Emax. You know, truly, you know, I don't find the need to do Empress anymore. I don't do a lot of feldspathic, but it can be challenging to know what materials are best. You know, and I would love to know in your guys' lab what you do the most of, And you know, any thoughts you have around material choice? And don't worry, Gil, next one's for you. So.
No problem.
Yeah, you know what? Of course, everything for the past few years, everything's been really moving towards Emax. And with our laboratory setup, we've always been with the Avoclar products, and we've always used Empress. And then when Emax came out, 10 to 12 years ago, we started gravitating towards that because of the strength of it there. Admittedly, when we first started using it, we were trying to use it in a way like Empress was, and it's a little bit of a different animal. So it took us a little while before we started making it look good. And it looks really, really good right now. However, in my view, I think that Empress does look a little bit better. So when someone asks me about materials and such, I will say, as far as like the best looking materials and everything, is that, all things being equal, I think that Empress looks better than Emax. However, if it's a situation where the patient is sort of like a little bit tough on their teeth and everything, and I'm a little worried that Empress may not be strong enough, to me, I'm willing to give just a little bit of aesthetics. And when I say a little bit of aesthetics, that some people probably would not be able to discern it there, but I'd rather give up a little bit of aesthetics for the strength of Emax. With that, with the feldspathic veneers, we had done that some in the past, but that's sort of a dying breed because it's very, very, very labor intensive. And honestly, those technicians that did that have kind of retired and moved on. And so that's why we've really, stuck with Empress and Emax over the years.
Okay. So along those lines, so Rob Soto in San Francisco, great friend of mine. I know he does a ton of work with you guys. I mean, just one of the most talented dentists right now, I believe, that's out there. So sometimes what happens is, look at Rob's work, for example, and his style. It's so beautiful and it's so symmetrical. And I think a lot of times doctors will look at that and say, okay, that's beautiful, but what color is that? Like, what ingot is that? And I remember when people would ask me, labs would ask me the ingot, I'm like, I don't know. I just get it close to the picture of the shade tab I sent you. I think it would be helpful, and I know you can't put everything in a box, but so like Rob is a great example. If with his work and a lot of stuff that you see, what would you say is the most common used ingot for Rob in his cases? And I'll go through mine next, just so people can kind of get a variation.
Right. So with Dr. Soto and I, we have kind of a understanding as far as like materials go. He knows about Empress also. So sometimes he'll do Empress, but most of the time what he'll do is he'll do Emax. With the Emax, just kind of a quick little overview. There's really 3 ingots. There's more ingots, but there's 3 that we use on a most of the time basis there. There's LT, which is low translucency, tends to be really opaque, and we use that to kind of block out darker prep shades. Medium translucency and MT ingot, kind of that in-between thing where it still has that blocking ability, but doesn't look as opaque. And then HT, which is a high translucency ingot, and it does look very, very good. I would say majority of the time with Dr. Soto, and his shades tend to be, anywhere from 1M1 and up, 1M1, OM3, OM2, every now and then OM1, but they tend to be in that OM2, OM3, 1M1 range. We tend to use an MT ingot based on the Avoclar shade grade, MTBL2, MTBL3. And then of course with the Emax, even with the Empress and everything, we cut back and layer that stuff. We layer the porcelain on top of that, and it's nice to have that base on there. But basically, the MT ingots tend to be the ones that are not too opaque but still have enough of the translucency that have a nice to let the color of the prep shade come through the veneer. LT is one of those things. You have a prep shade that's probably like an A3 or an A4. You don't want to have that prep shade showing through as much, especially if you want something of high value. HT ingots are very, very nice. They look really, really good. They tend to burn you a little bit there too because the HT ingots, since they're high translucency, they can't block out dark prep shades as well as the MT ingot. So actually, the funny thing is I think the HT ingots look absolutely beautiful, but 2 things, like I said, the dark prep shade will kind of kill it, and sometimes they just don't have that pop of a high value. In other words, it's kind of a natural look. If a patient is actually patients worn temporaries for 2 or 3 weeks that have been kind of opaque and kind of a high value, you put an HT in, which is a nice translucent, they kind of go, oh, It
Yeah,
just doesn't have that pop as much.
yeah. So that's a great way to explain it, and I'll translate that and simplify it, because I think just getting off the conversation of color and not overcomplicating things. If things are trending brighter, the last thing you want to do is put in an HT and have it look too gray or too translucent. So in my practice, so if you go to Dr. Rob Soto's Instagram page, for example, you can look at his cases, and what I heard Brent just say is most of those are going to be either like a BL3, so Emax, all of them, BL3 MT or a BL2 MT, okay, medium translucency. So then if you go and switch over to my page, for example, most of my cases are either BL2 MT or BL2 LT. So I think most of your cases, if you really want to start doing more cosmetics, what the patients nowadays are wanting is anything in like those three shades. It's either like BL3 MT, BL3 LT, BL2 MT, or BL2 LT. I think that kind of simplifies it. And then the people want something more natural on this side. The people want something brighter on this side. When you get into that BL1, it's crazy bright. I mean, that's for those that want the white. But I think anything less than that, unless it's to color match canines, or something else, I think that's kind of where things are trending. So if you want just like a starting point, go look at those 2 pages, and that can give you an idea on color and what to choose. Then it makes it real easy. Now you just send a case, you tell Brent, hey, I want BL2 MT, and you kind of know what it's going to look like when it comes back, and you get exactly what you want instead of trying to guess.
And I think it's a good thing for as doctors, they start to get going with, start doing some more Smile Design cases. And I know you and I, we always have a little bit of a conversation. I think it's always good for, Smile Design case, have that 10-minute conversation with somebody at the laboratory. And that's what you and I do. That's what Dr. Soto and I do, and a host of other. And then discuss, ask your laboratory, hey, what ingot are you thinking of using for this here? So you get an idea of what ingot looks like in the mouth. So when you get the case back and put it in, write that in the patient's records, and then when you take some photos and look at it on the screens, you go, okay, that's an LT-BL2. Now I know what that looks like. Then you're going to get pretty good at actually, I've got some dentists that work with us. They're actually very, very good about calling out ingots, because as many cases I have seen chairside, way more I've not seen chairside. And I always say the doctors are right there seeing it. So I want them to, even in the photos, sometimes I can get a good sense of it there, but when you're seeing it right there, you're going to be able to see how it looks. And especially on a callback, a couple weeks later when you get them back in, after the teeth rehydrate, how does that ingot look? Now I know what that LT-BL2 looks like. Now I know what that NT-BL3 looks like. And if you I know we keep going back and forth, but Dr. Soto is very, very, very good at that. And now he's seen it, because you get such a library thing. It's a good learning process of what works, and frankly, what doesn't work. Sometimes I've made a lot of what like anything, a lot of what we learn is like doing the wrong ingot.
Well,
it's like one of those things.
It's that. I mean, the more you do something, the more comfortable you get. And one of my lab technicians joked with me one time. He sent me a picture. It was a paper towel that just had the patient's name and like the shade on it, and that was it. And he's like, "Come on, Brian, you're getting really lazy here." But you get in this rhythm, right? And then it just becomes like second nature. So let's shift gears a little bit. Gil, I want to hear from you. So Gil,
sure.
You're probably the most famous dentist, non-dentist that I know. That probably gets more inquiries than anybody else from patients. You're actually not a dentist. So tell us, I'm going to shift a little bit, and then we'll come back to some more clinical stuff.
Okay.
Explain briefly, because I know it could be like a 40-minute deal. Briefly, like how you got into social media, and then maybe some advice for doctors on how to get started if they're stuck.
Sure. So the very brief thing is, 2 years ago, I did not know what a hashtag was, or face chat, or Snapbook, or Insta, whatever it's called, right? I didn't know any of these things about social media, but when Brent and I were talking about it, we started seeing a lot of our doctors on social media showing off their cases. And I said to Brent, we got to get ahead of the curve a little bit here, because we get obviously a lot more cases than a single doctor might get. So I said, how do we work this so that we can promote our doctors that are out there. So if you see my page, I'm always promoting our doctors. It's a lot better to brag about you and Dr. Soto than it is to brag about us at Frontier, right? So that's kind of what we do. And the fact that Dr. Soto uses this, and doctors all across use this, it's social proof that says we're doing the right things. And so when we've done that and we started working this more and more dentists would reach out to us. And the first time a dentist came to Brent and I said, hey, I want to send you a 16-unit case. I want to send you a full mouth rehab. We've never talked to the doctor. We've never done a single unit posterior for them, but they had the faith and trust in us to do that. And so it's really just gone from there. Now we've been very innovative about what we're doing with social media in terms of how do we best make our dentists successful? Because when they succeed, we succeed, obviously. And you mentioned something, Brian, the patient-driven process, right? You can't hide it. I mean, with our cell phones, we have access to anything now. So what we figured was let's inform, educate, and entertain patients so that they can go to their dentist and say, hey, I saw this thing about Frontier Veneers. I saw this thing that Dr. Harris, this smile that Dr. Harris did, whether they're going to you or they're going to somebody else. Can you tell me more about this? So now you have an educated patient that knows what they're looking for, that knows the value of a beautiful smile. And now it's a much better conversation than for that patient to come in blind and say, hey, Dr. Harris, do you do veneers? So it's a lot different conversation. So everything you see from us is how do we help our doctors? And that's actually the very reason we're on this webinar with you today is I saw the Smile virtual platform as a way to help our doctors become better at cosmetic dentistry, to show cosmetic dentistry, and if those doctors succeeded, then in turn those cases will come to us and we'll be able to make beautiful smiles like Brent said. Was that good? A good synopsis? And
yeah, that was good. And you know, I think the biggest takeaway from that is the fact that the power of social proof. You know, the power of being able to show the reason a doctor would send a 16-unit case without even knowing who you guys are, is because they're able to look at the work you do for other doctors and the trust is immediately built. So what happens on the patient side, and the way this applies to each of you doctors that are listening right now, is it's the same thing when patients see Susie had her teeth done and Joe had his teeth done and Carrie had her teeth done, and they start to see other people that they know had their teeth done, or even if they don't know them, they look at a picture of somebody that you post on your page and they say, oh, he or she looks about my same age and she was able to get it done, like I deserve to do this too. And if I'm going to do, it's what I call the law of the herd, right? Naturally, like animals go in herds because it just makes more sense to just do what the rest of the herd is doing than try to go off on your own and find a new way. And so people are the same way. They will look for what they perceive more and more people are doing, and then they'll follow that. And the tendency is to have a mindset of scarcity of, oh, well, you know, Dr. Harris is already posting stuff, or Dr. Jones down the street is already posting stuff. There are millions of patients out there in this world right now that want to improve their smile, that have no idea who to trust. They have no idea what to do. They have no idea what things cost. If you just put yourself out there and if you just build an awareness, like they will come. I've seen it. I see it in all the doctors we work with. Like it happens. It's a totally new way of seeing things. So
yeah, I can add on to that a little bit. I mean, we've only been at this on social media for less than 2 years, and we've grown, gotten new doctors, and we've had a chance to work with doctors. And what I tell them, they're asking us for advice. What I tell them is, how does a patient get to know you if they don't see you at McDonald's, at the soccer games, at the supermarket, you know, going to a local football game on a Friday night? When they see that that's what you're all about, and then you've got a couple kids and you're Dr. Harris in the community, they already get a chance to get to know you. I mean, I don't know how many times a doctor will call me, or if I show up at their office, they'll go, oh, wow, I feel like I already know you. They already know my kids, my dog, whatever. What better way for a dentist to get themselves known in the community by showing themselves on social media? And you don't have to give up your whole life. You let them know whatever it is you want them to see. And if you know, social, it's what it means. It's social. If you're being social with somebody and, you know, you're a good guy, you're a good person, the patients will pick up on that. And when the time comes when they need a dentist, they're going to remember that.
Yeah. So I'm going to read something really quick. I got this today from a patient. I've never met her, but I think this is to kind of put a pin in this conversation to move on. She messages me and she says, Okay. She said, would you be willing to share what lab you use? I've gone to a few places here and it seems like more than anything, it comes down to the lab they use for the products. So she's gone to a couple places, had work done and not happy. Patients are starting to recognize that, a big part of the success in cosmetic dentistry is the lab. And so when I talk to doctors, so let's shift back, let's go back clinical now. One of the biggest pieces of advice I give, whether it's Frontier, whether it's any other cosmetic lab that's out there that has a good reputation, find a good lab that does this work day in, day out, and use them. Don't worry about the difference between, a $200 lab fee or a $300 lab fee or 150 versus 300. When you find somebody that's really good and use them, they've been through the process over and over and over again, your results are going to be better. And then when you go and post those cases, because your results are better, you're going to get more referrals. And it's like, I think it's the one missing piece that a lot of people miss out on is they look at the cosmetic procedure as, oh, somebody signed up for 6 veneers. And they look at that as like production. And they look at that as like, I'm going to complete the 6 veneers and it's done. If you shift that mindset, every time you have somebody come in for a cosmetic procedure, if you look at that and say, awesome, because they signed up for 6 veneers, if I do this right, this case is now going to get me 2 other cases because I'm going to nail the aesthetics, then I'll be able to post it on my website, on social media. And from that, it's social proof that it's going to attract more patients to come see me. So I think that's, what we're talking about, how to get better aesthetics. Find a good lab. Find a good lab who knows what they're doing. Find a good lab who's willing to tell you if there's things that you need to improve, swallow your pride a little bit and find a lab that's willing to pick up the phone and say, like it happens to me a lot. Brian, you under-reduced a little bit, right on the facial incisal. Can I make a reduction coping so I can give you ideal aesthetics? A good lab will do that. And then I'll tell them, oh yes, do that please. Because now, instead of them having to build everything out to where that spot I under-reduced and now everything looks bulky, they'll cut that spot back, make me a reduction coping. Now the case looks ideal. If they're not used to seeing that type of stuff, they'll just make the case and it's bulky and then you get a result that doesn't work. So a long way around the next question, Brent, what do you think the biggest mistakes, if you see doctors make mistakes or if you get a case and I'd ask you to be like real and raw for a minute. If you get a case and you look at it and you're like, you get frustrated because your hands have been like tied in some way by something that was done. What are some of the most common things that you're seeing?
Right. What that I see pretty much on a daily basis there is not so much under preparing the teeth, but that is a little bit there because you're right. You kind of hit on it there. Usually the biggest things we want to roll in that incisal third. Just want to pull that back a little bit, just so there's not a hot spot coming through the veneer or the crown. But the big thing that I see is, and of course I'm all about being conservative and stuff like that. But in order to achieve the results that the patient needs, a lot of the times we need to break the contacts. Okay, and because here's the thing. And by the way, it all really starts with the diagnostic wax up. I mean, you've done a million of these things. Like we go back to Dr. Soto. Dr. Soto has probably done hundreds and hundreds and hundreds of cases. Every single time he does a diagnostic wax up, he can probably actually prep a case in his sleep without even using a wax up and everything. But he goes back to the formula of a diagnostic wax up because people have different smiles, and sometimes you have got teeth that need to shift over. You got teeth that are just proportionally off, and so what happens is that we make a nice diagnostic wax up. The doctor approves it, the patient approves it there, and then we're narrowing teeth out. And so if we do a veneer, and let's say, for instance, the natural tooth is like 9 millimeters wide, but the wax up with the proportions we want to go to 8.5 millimeters wide, but we don't break the contacts. Now we're trying to make an 8.5 wide central on a 9 wide prep, and it gets really, really funky. And so, and then the other thing too is like, especially if you've got crowding or the canted midline that you want to straighten out, meaning, you've got a midline that's canted like this, and you don't break the contact, so then the veneer is going to come down like this, and we've almost had to wrap a veneer over the top of a midline, and that just kind of it works, but sometimes the eye, like there's something going on there, you know? And so I say you have to like, you know, slice through and make sure that all your preps are in the zone. And, you know, not just with the diagnostic wax, but you have to use the matrices, a lingual matrix, so you can put it behind the teeth to make sure all the preps are in their zone. And then also a facial matrix to make sure you have enough facial reduction. You know, again, I'm the armchair quarterback here. It's easier said than done, but that's you know, one of the things that I see, the third plane reduction there and the breaking the contacts more often than that. And when you break the contacts, go ahead and slice all the way through, because sometimes they'll open up the contacts and they'll leave little spicules of enamel. A couple things on that. The impression will tear coming out of the mouth if it's a polyvinyl impression there, and then if it doesn't tear, when we pull the model out of the impression, either the model will chip or the impression will tear. And I always like to have multiple pores because I want to make sure everything fits. And so being able to use your matrices and everything. And the other thing, which, you know, we'll probably talk about a little bit later as far as material goes and like that, the biggest problem I see with the ideal case is one bad prep shade ruins it for everybody, you know. And if there's anything that a doctor can do, let's say you just got a root canal tooth on number 9, it's one of those things that it's like, it is so much better if the doctor takes care of that chair side than us trying to block it out. I mean, what I would try to put some composite on that, on the whole tooth there, not just the facial and the lingual. Sometimes what they'll do is they'll put composite on the facial, but they don't do it on the lingual, and then you'll still get darkness and it'll kind of go down, you'll kind of drop the value of that one tooth. But your goal is to try to get all the prep shades as uniform as possible if you've got root canal teeth and everything. So sometimes what happens, we'll say they'll prep it, they got some dark stump shades, and they said, okay, well, this is what I want. And it's like, well, I've got to cover this up, and we got to change materials and things like that. And so I try to stick with one material for everything, rather than having a porcelain fused zirconia on 8 and a veneer on number 9, things like that.
And yeah, because now with Emacs you can do that. And one thing, if you're able to take notes, one of the things that I use constantly for those type of issues is a product from Cosmetic. It's a enamel, it's a flowable, but it's called Pink Opaquer. There's other companies that make it, but what it is, it's a pink flowable composite, but it's really opaque. So it looks like if you took white out and put a little bit of pink, but because that pink is kind of that complementary color of the darks and the grays, you just prep it like you normally would, take away a little bit more on that dark tooth, and then you can etch it, bond it, and then just go and flow a little bit of Pink Opaquer all around it, lightly prep it again, and you'll get what Brent's asking for. Because then, even if it's not the exact same color as the other teeth, that Pink Opaque is really easy to match to the other teeth as opposed to the dark gray. So yes, I would agree. Blocking out stump shades is crucial. And going back to the thought on prep design, what happens is we get torn because in this year it's like conservative, like don't take away more enamel than you need to. And it's what's the word I hear often? Responsible aesthetics. It's all these things, which I am totally for. I see, and I have guys in my mastermind group. Dennis Wells is one of them. There's a close friend of mine. We're in the same mastermind. This guy's a magician at no prep veneer.
Amazing. He's amazing.
He's so good. And his whole thing is like, he's like, Brian, I try to not ever prep. And that is like, I mean, it's amazing. You have to really know how to do that. But then you have over on this side, people that are just doing full coverage on everything, right? So if you can be somewhere in the middle, in my opinion, and if you're gonna prep, you might as well just break through the contact. Then it gives the lab total freedom. Now they can move things however they need to. They can change the width of the teeth. They can change position because they're not stuck and they're not, restricted to where the contact is. So that's more of like a personal decision of how much you want to prep. What I find works best is more of a minimal prep, break the contacts if you need to make big changes, and give your lab room to give the best ideal aesthetics. When you see those cases posted where, and it's obvious because if you look at the before and then you look at the after, if the after looks beautiful, but the neck of the tooth is a little bit more narrow than the before, well, that's because they've prepped some in there and given you room to work with. So, yeah, I agree. I got a couple questions here. this is for you guys. Are most docs still impressing or scanning, and what's the lab's preference? I'll let you answer that, and I'll tell you my.
Yeah. Okay. So that's good. You know what? Definitely, it's starting to. I think we hit the tipping point where it's actually starting to be more of scanning. And just for our laboratory here, we're now probably about getting close to 30% of our work coming in is from intraoral scans. So it's pretty incredible. That said, I feel pretty comfortable about doing a smile design with scanning. But I got to tell you, there has been some times where it's an intraoral scan. We'll get a model. And then we've had problems with fit on them, and then because, I won't say the name of the companies or anything like that, but because, we didn't do the model, we didn't do the scan, the other company marked the margins like that, and then it gets to things like, well, I made it on somebody else's model and it didn't fit in the mouth, and it fits on the model. So I'd say probably that happens maybe 10% of the time, so not really that much there. Single units, I feel great about, posterior stuff, single anterior, stuff like that. You got a full arch thing, a full upper and lower. I get a little bit sketchy on that. In fact, what I would probably do is if you get your toe in the water, I would do maybe both. Take an analog impression and take a digital impression just to be on the safe side type of thing. But we are seeing more and more. The technology is getting better and better on that. And it's really good.
It'll keep getting better. My preference, I have the iTero in my office. I have the OmniCam in my office. I have the technology to do it. I find that I get more predictable results, and I just have more peace of mind taking impressions, and I impress everything. Yeah. I use a Cavo Kerr product. It's called Take One Advanced. The reason I talk about that product a lot is because when you use it, it will find those margins, and it goes in all the nooks and crannies. I don't pat cord. I never have. I've never found the need to, because you find the right materials, and if you can get good isolation, it will find your margins and get great results. And so I still am impressing everything, and I probably will be that way until I feel like the technology is there to make that shift. Okay. This is a good one. It says, is it better to do canine to canine or better to include premolars as well? I'm probably one of the few doctors that I still will do a lot of 6-unit cases, because I think it's doable. I think you can get great results, but it's tough. It's really easy for them to get a little bit too bulky, or it's really easy for them for you to see kind of like a color shift. I would say a lot of time that's driven more by what the patient can afford. And so if my patients are tapped out at 6 units and that's where they're at, I'll do one of two things. I'll either give them the option. Well, sometimes if I know we can do it, we'll just do the 6 and make it look as good as we can. But if it's somebody that's like, I want to go really bright, and they're like an A2 in the natural shade and they want 6 through 11 really bright, I'll either include the 2 additional units, one on either side, and have them pay lab fee only. Or sometimes I'll seat the 6 units, and then I'll get like an XL1 shape global composite and just do a little bit of composite buildup on the premolars, and that works really good too. You guys fighting over there?
Yeah, he's messing with. Stop pressing buttons. All of a sudden, you disappeared, and I freaked out. You disappeared.
To answer that, I would say yes. Whenever possible, try to stick to 4 or to 8 or to 10. But at the end of the day, I probably have 50 6-unit cases out there, and some of them I don't love. Some of them turned out really nice. And so don't think there was this old rule of like, oh no, you never do 6, you only do 4, you only do 8. You can do 6. You just need to prep right, do a wax up, work with a lab that knows what they're doing. Okay.
So you know what? Let me say something on that too, Dr. Harris. Is that you're right. About a few years ago, there was this thing that goes on the lectures, like never do 6. You should just tell a patient, well, of course you can do 6, you know? And so sometimes what I would do with people is and I say, well, how come they're not doing more than the front 6? And they say, well, you know what, I know this person, they can afford it and stuff like that. So what I would do is I'd do a diagnostic wax up and everything like that. I'd throw in the second bicuspids, and when they did the temporaries, or if they did like a little trial smile or something like that, they put it in there and they go, how do you like that look? And they say, it looks great. And then they flick off the composite on there, like, put them back. I want them back, you know? And so it's a good little technique, actually.
Well, that's
a
powerful way, and they need to see it. And at the end of the day, if you have this mindset, remember when I talked about that 6-unit case, don't look at that 6-unit case as like you do the veneer case and then it's done. Look at that and say, okay, if I nail this now can help me get 2 more additional cases. So if nailing the case and making it look great means adding a couple units on there, and it means you paying an extra like $500-600 to do it, but now you can post it and it'll look amazing on social media, use that. Look at it as a marketing expense, do it right. And whether the patient can afford it, whether you eat the cost or whether you say, you know what, I'll let you pay this out over a year, just pay monthly payments. Start looking at cosmetic dentistry as like every case is a continuation of the last case. Every case you do should lead you to more cases if you do it right. Okay?
Right.
Okay. Let's see. Let's talk. Okay, good. Another question here. And then I got a couple other thoughts I'll share. And then Gil, I guess I should leave room for you guys to ask questions too. I'm like dominating the conversation. So this is another quick one. We'll get this out of the way and then I'll let you go because we got about 15 minutes left. So pressed versus milled restorations. I prefer to have mine pressed, waxed and pressed. Some of the milling's getting like amazing. Now there's the kind of a combo because there's milled wax that they can press. But what would you say as far as traditional cases go? How much are you pressing? How much are you milling? Is there pros and cons one versus the other?
Yeah, here's the thing. As far as press, 100% of our Emacs and Empress are pressed. Okay, a couple things on that. One, I think you get better margin, you get better fit when they're pressed restoration. 2, a few years ago when I was up at the Coyce Center, Dr. Coyce reported that actually the pressed is actually a little stronger than the milled restorations. And so you always have to listen to what Dr. Coyce says. And then number 3, I'd rather mill wax. We actually do use about half of the work is actually milled wax now that we touch it up by hand. But milling wax is much easier on my machines than actually milling a hard, even in the blue state, it's still kind of hard on the mechanism and everything. So we press everything. Mm-hmm.
Okay, same. I'm not going to skip this question because this is good. So the question is, have you ever used multi-layered zirconia for anteriors if the patient is a bruxer and looking for a smile makeover? This is the one that I've seen a lot of doctors get like really burned on, and it has to do less with the material than it does like the bonding and cementation process. So what I would say is, if designed correctly, Emax is plenty strong for those bruxer cases, okay? But I have had a couple patients where when you look in the mouth and it's like flat and like looks like cow's teeth and everything's worn down, I've had a couple cases when they end up being more like full coverage cases that I'll go to bruxer and have it be, especially with the new like Zircad, like the Prime, that stuff looks really, really good. I stick with it mostly for full coverage cases. The reason being, even with Ceramir and even with Zirconia Primer and all these things, you're not going to get as good of a bond strength bonding Zirconia. So what happens is I've had doctors do these cases. They'll do 10 units in Zirconia and they'll do veneers and they'll bond them all in, and then things will start to pop off. Things will start to delaminate because of the cementation or the bonding process. And that's one that I would say be super careful before you go down that path. Make sure that you really know what you're doing with materials. Okay. Okay. Gil, got any? For me, if not, I got more.
I see one question here. What is the Instagram page for the doctor and this lab? So yours is Dr. Brian Harris, right? DrBrian Harris?
Yeah, just at Dr. Brian Harris. Yep.
Okay, and ours is at Gil, my name, _Frontier Dental. And you'll find all the information there. So one of the questions I have for you, and I'm humbled by your nice words of me in the beginning, and you know I was very impressed the first time I met you, and it was through social media actually. Two parts of the question. How did you make the pivot in your practice from being a general dentist to now only doing smile designs? Because I saw where you're booked out for weeks and months at a time, and you're just doing cosmetic dentistry. So that's question number one. The other one is, what role does social media have, and how do you use it to promote your practice?
Okay, I need like an hour. So as long as
I know.
you stay late. No. So here's my thoughts. Let's talk about the first one. I believe like we're living in a time right now unlike anything that has ever been seen in our profession, and there is more positivity around dentistry and technology and cosmetic dentistry than ever before. At the same time, there's a lot of like trust issues with patients and dentists because patients are more educated. And so about 3 years ago, long story short, about 3 years ago, I wanted to start doing more of the stuff I loved. You know, and at the end of the day, I had done 2 smile cases in one day. I was telling my wife about it. She's like, why don't you just do that every day? I'm like, well, it's not easy to just only do the stuff I love. You know, and that's when she's like, no, you need to just post your cases on Instagram. And at the time it wasn't cool. It was weird. But I took her advice on it and I started posting. And what happens is when, you know, everybody knows you're a dentist, but nobody really knows what you do until they see what you do. So when you show the world like, hey, this is me, this is what I do, then all of a sudden people start asking questions and people start reaching out. People we went to high school with, people in the neighborhood, people you go to church with, they start asking questions, and it now gives you this platform. So instead of like waiting for people to come to you, it gives you this platform for now you get in front of people and just answer their questions. And so people started reaching out and I would respond to their questions. And it started, I mean, the big shift is when I started doing virtual consults. And, you know, instead of telling people when they had questions, come in and see me in the office, you know, I would get on a recording platform. It was really cumbersome back then. It would take about an hour for every consult, and I would record a video and send it to them. And it built this like immediate sense of trust with the patient. And what I started seeing is they were moving forward. Like once they came in to see me in my office, it was a 90% close rate on high dollar cases, which national average is like 30-40%, right? But they were coming in because they already felt like they knew me. They already felt like there was a relationship. I'd already gone over cost and details. And that's when everything shifted. And so those that don't know my story, you know, there's a webinar that I do, you know, just reach out to me. I'll get you access to it, just a previous recording of it. But it tells the whole story, and it tells about how Smile Virtual was born from that. But essentially what happened is I started doing more of these virtual consults, and my schedule was full, only smile cases, you know, and I thought, this is crazy. Other dentists need to be doing this. And so I got about 12 doctors using the platform I was using, and they started seeing it. And then that's when I said, okay, you know, what we're doing right now isn't HIPAA compliant. There's, you know, we were kind of breaking a lot of rules around the process of what we should be doing. So that's where I went out, invested, and built out the whole Smile Virtual platform. And the whole focus of the platform is in the methodologies. We teach dentists exactly how to do what I did. So we teach them how to go out, build their brand on social media, build their brand on their website to drive virtual consults. Then we teach them how in the virtual consult, like what to say, how to say it, when to say it, to get them to actually say yes, but do it in a HIPAA compliant way. It's the only platform out there that's HIPAA compliant. And then we teach, like once they're in the chair, how to get them to move forward and get the predictable results, kind of like what we started the conversation talking about. So that was like a long-winded answer, but virtual consults have been probably the number one thing that has shifted everything for me. The other thing has been social proof, just, you know, really focusing on getting decent results and then showing the world what it is that you do. And I've seen doctors have success with this in the middle of Salina, Kansas, as well as like, you know, Rob Soto in San Francisco. And I've seen, you know, AACD accredited dentists like crush it with this, and then doctors in small towns in Canada do well with it. So it's much more about how to connect and communicate with people, how to get in front of people than it is about anything else.
Well, as you know, and I've shared this story with some of the others, that's how I first got connected with Smile Virtual. I saw a lot of our own dentists, our own current clients, that were showing their cases through Smile Virtual. They were saying, click on the link of our bio in order to download your selfie and that type of thing, go to Smile Virtual. So I just started putting it together. Wait a minute, these doctors are very successful. We're getting a lot of cosmetic cases. How can we get the rest of our doctor population more successful? And that's why we started working with Smile Virtual, and that's why I looked you up. And then the more I saw what you were doing, I said, this just makes sense. And it's been such a good partnership, because for us, it's all about social proof. It's all about showing who we are and what we can do.
Well, yeah, and I think the hardest thing about being a dentist, in my opinion, is knowing, like, you can go to a trade show, for example, or you can get mailers, you can get magazines. It's like we're flooded with all these different things that we could, like, do we buy a cone beam? Do we start doing sleep apnea? Do we do short-term ortho? There's all these things, and all of them are helpful tools to do more of the stuff you love. But what we forget is, like, geez, if we can just master this way of communicating and controlling the sale process, now you make the whole process so much more efficient, because now you get to do more of the stuff you love, and it's in how you communicate with these patients. So, I know time has gone kind of fast tonight. There's other questions here. I think, so I'm going to do a quick, like, shotgun of these last 3 questions, because I don't like leaving people hanging, and then I'm going to wrap up. So prep design, guidance on prep design. Actually, what I would say on this is I'm going to let Brent and Gil teach you this. If you want to really know how to design a case, like, and I don't want to put you guys on the spot, but if you guys would be willing to help some doctors, like, if they've got a case they want to do, Brent, just get on there and say, hey, I've seen the most success with these cases. Do a slice prep. Here's an example of what slice prep looks like. And this is, just follow this protocol and you're going to get great results. Next one here. How often do you send to ortho before cosmetic work? Depends. This is, for me, is much more patient driven. And that may sound like a cop out. That may sound like, oh, you just want to do the case, you don't want to do ortho. No, I would prefer always to get teeth aligned first before we do veneers. But you're going to find there's not all patients are the patients that are going to go through the ortho and then go through the pinhole technique to get that little bit of recession down and replace, all of their amalgams, and go in and, and do all these things and do the cosmetics. Some people just want you to help them improve their smile. I mean, there's people out there suffering, like, low self-esteem, hating their smile. They just want to feel better and look better. And sometimes I feel like we put up all these barriers to give that to them. Okay. So with that being said, is I always try to straighten the teeth first, but there's ways to still be conservative. If you know how to design the case right, there's ways to do that and still get amazing results without doing ortho. An example of this is, I've had patients come in that they've gone through Invisalign, widen the arch to try to get the look they want. And now they have a nice wide arch, but they still hate the color of the teeth and they still hate the shape of the teeth. They want to go and do 10 veneers. Well, now what I have to do is I got to go and prep all those teeth back to be able to get the right result to get thickness. Where if they would have just left the arch more narrow and we would have done minimal prep veneers, we could have got the same result without having to really destroy any enamel. So it's kind of a complicated question. That the answer to that is very dependent on the patient, the case, and, like, think it through, but don't get stuck in this box of, like, oh, no, you have to do this, then this, then this. But also don't be reckless either. Don't go and just aggressively prep a case because you want to get that case done. Okay, one more. I'll let you answer this quickly, Brent, and then I'll close up. How do you handle deep bite cases, with Shibashi, and it says with 10 veneers? So I have kind of my thoughts on how I'd handle it, but how do you handle deep bite cases?
Well, deep bite cases, and if we're only going to do 10 veneers or 10 crowns, so that there's no plan on opening the bite and everything, those deep bite cases, sometimes they tend to be, they might need to be lengthened gingivally. And so, because that's kind of what they see. There's so much overlap and everything like that. You don't really see that and such. But really, as long as the function is not that bad and they just have a deep bite and everything like that, I just think that we can kind of do the same type of protocol. If we are going to move forward and do a, open the bite and do, upper and lower arch or something like that, the best way that I open bites and everything like that is if we just use the Coisty programmer. It is just one of the best ways to open bites. To me, it's one of the best simple inventions of all time that gets the patient to get that jaw where it wants to be and where it's comfortable. So that instead of somebody shoving somebody in CR or manipulating, the body finds where it wants to be and the mandible goes where it feels most comfortable. Then we build a case based on that. But sometimes patients don't want, they just want to look better and stuff like that. But don't forget that sometimes gingival architecture is needed to lengthen gingivally on those deep bite cases that I see.
Yeah, and I think sometimes what we get stuck by just looking at measurements and looking at function, and you always like function first always. But sometimes what I've seen is we see a case that's a deep bite and where we could go ahead and restore them and do 10 veneers and it's still physically, it will look like a deep bite. Or we could go and do 12 veneers or 14 and open their bite and change their position and change the jaw. Or the same thing with ortho. You put somebody through ortho to get the bite where it wants and then do veneers. I think it comes down to this idea of is it better to mess with something if it's comfortable and if they've lived with it for 50 years and it's comfortable and they have no joint problems, no pain, they're not concerned about it. Is it better to just restore them where they're comfortable, or is it better to go put their jaw in a new position, widen the arch, change the bite, move around teeth? Well, I think that's like a really fine line that I wouldn't discuss, without having like a 2-hour lecture behind that. But I think sometimes we have to think about like what is at the end, like what is truly best for the patient in their world and what they're going to be living with, is doing more and doing additional work going to complicate their life, or is it going to help them? And that's a decision you need to make. So I know we're out of time and we'll have to do this again because this was awesome. I think there's so much to learn in this environment, but what I would close with is this, and this is what I've learned for the last 3 years. So in the last 3 years, I've only done Smile Makeover cases. And 3 years ago, I was a dentist, just a general dentist that liked to do cosmetics. Where things shifted was, me getting really clear on what it is that I love to do and what it is that I wanted to do. And then also me getting really clear on like giving myself permission that like, it's okay to do the stuff you love to do. And it's okay to be selfish in the profession and say, you know what, like, I don't have to see everybody, because if you don't love doing a procedure, like, would you want to go to a surgeon that the whole time they're doing your surgery is like a freaking hate gallbladder surgery and never want to do it anymore? You want to go to somebody that's like passionate about it. And so sometimes that attitude of like, I'm just going to do everything, but I hate doing it, like it's a total disservice to your patients. If you can get real clarity on like, hey, this is what I love to do and I want to do more of it. The world we live in now, like there's a real clear path to be able to say like, hey, here's where you are. Like you can go and create that. You can actually get there if you have the tools. And some of the things we talked about tonight, like I think 2 of the biggest tools to get there are like using a platform like Smile Virtual to know how to communicate with patients, know how to attract more of those types of patients, do more of the stuff you love. And then once you have that, like partner with a good lab that knows what they're doing, that will make your life really easy and deliver every single time so that it really does become fun, so that you become the master at doing that type of dentistry. Because, it's kind of a funny thing, but the better you get at something, the more you do of something, the more you get of that thing because you're an expert at it. And so with that, I would say, guys, thank you. That was awesome tonight. Like I learned a lot. I know everybody else on the call did. And for those listening, I hope it was helpful. I hope we kept our word and just showed up and delivered value. And I hope you guys have an amazing night and a great rest of the week.
Yeah. Well, listen, thanks, Dr. Harris. It was a lot of fun. I'd love to do it again. And, just a couple shout outs because we see who's on the call. So a lot of our clients have, but one person that I want to shout out to is that Dr. Ingrida Ivans. She's in Lithuania and she's on right now. It's 3 in the morning in Lithuania. So that's dedication. She just got accredited. She just got her accreditation last year at AECD. and a lot of people that we know. And so this is just, I love the platform, Dr. Harris, and what you're doing, because you're giving back to dentistry. A lot of the people that that are on this call that know us, something like that, have been doing veneers with us for over 20 years, and they're here learning more of what they can do. And I think that's very, very special. So kudos to you, and we love what you're doing. And I think the Smile Virtual is a beautiful platform for us all. So.
Well, my last word is, again, thanks to everybody. Let us know. I don't know what the mechanism is to let us know if you want to continue doing this again, but I can see us making this a regular thing, because between mainly two of you, there's so much information to be shared, to have the leading cosmetic dentist and the leading lab guy. We actually estimated once, Brent won't brag about himself in his true nature, but we estimated that he's seen over 27,000 Smile design cases have passed through his hands and eyes. 27,000. I mean, who else in the world? He won't brag about it, but I will. Who else in the world has had that kind of experience with these Smile design cases dating back to what Brent said? So again, if you like what you saw tonight and the format that we did, let us know, because we're happy to share this information with all of you. Okay, thank you very much.
Absolutely. Good stuff, guys. Have a good night.
All right, guys, take care.